Hello, today we are diving into one of the most life-threatening yet fixable ECG patterns you'll see. Hyperkalemia. It's sneaky, it's deadly, and it's 100% worth mastering. It came up on the Google Forms as one of the topics that you wanted me to explore, and because of that, we're going to be going into it. I have some resources. I might share one of them on the group. But basically, hyperkalemia means too much potassium in the blood. Potassium helps your heart beat properly, but in excess, it can become a silent killer. So you think of potassium like a salt in a soup, it is very tightly controlled in the body. So you need just a little for the soup, or you need the amount that you need. But once it goes beyond that, it becomes too much. And the flavor, too much flavor ruins everything. So in this case, the too much potassium stops the heart. Hyperkalemia um, is important because the heart runs on electricity, and potassium is a key electrolyte that controls the way the electrical signals move through the heart muscle. When potassium levels get too high, the signals get very confused, and the heart can slow down, misfire, and in severe cases just stops. So we want to tightly control it to prevent arrhythmias. And so that if you remember the four H's and four T's, that is the reversible causes in a cardiac arrest, you know that hyperkalemia is definitely one to watch for. It's one of the four H's. And it just means that we need to see if we can reverse any cardiac arrhythmias or any cardiac arrest by also checking what the potassium is. Now, the ECG changes in hyperkalemia show a very predictable pattern. Um, I might be able to share you something on the group where that is that lists all the things I have said. But basically, the first signs of hyperkalemia that you find is tall tinted T waves. This could be your first clue. Now, in real life scenarios where I have seen high potassiums of between 5.5 and 6.5, and I do not have any real reason to believe that, for instance, if for many days they've been on the ward and all of a sudden they're calling the crash team because, or they're calling the medical emergency because the potassium was 5.6, 5.7, I usually tell them while I'm making out time to come to the scenario, I tell them just repeat the potassium because a lot of times you could have high potassium, which could be pseudo hyperkalemia, in which case it is not a real hyperkalemia. What you're finding is the fact that maybe they've occluded the veins, sorry, the veins too much. What's the word? I'm trying to remember the word, but you know when you tie the arms to get the blood from it. So they've done that a lot, and then because of that there's some breakdown of muscle, or they've taken the sample for quite a while and it has laid around, maybe the entire morning on the wards, or taking some time really basically, and then the cells have begun to lyse, and in which case you could have a false reading of hyperkalemia or even lab errors, but that is quite rare, isn't it? So my point is that if I get potassium in this range and I do not have a definite cause, they are not on medications that could, like potassium sparing medications. They're not on some medications you use in intensive care, like for instance, succinil. They are not on spironolactone. They're not on medications that could explain the high potassium. What I would do is repeat it to rule out a hyperkalemia situation. Of course, in any situation, context is key. I might not even wait to repeat it. I might have it repeated, but not wait for that to take action if my patient is already symptomatic for hyperkalemia. That being said, we would go into the ECGs, but I wanted to mention that the first signs you will see are tall tinted T waves, and the tall tinted T waves are significant because in this case they are symmetrical. I know we've discussed hyperacute T waves before, which may be asymmetrical, but in the classical T wave for hyperkalemia is tall tinted, symmetrical, and having that's why we say tall tinted because it's as like a mountain peak. It's usually seen in the chest leads, that is the V2 to V4 leads. Now, in moderate hyperkalemia, the P waves flatten or disappear completely. And In moderate hyperkalemia, we say that's between 6.5 and 7.5. The PR intervals get longer until there's a delay in the heart start signal. For the severe hyperkalemia, what you now have is a wide QRS. So I like a short video. It's been circulating for a long time where you can see how the rhythm of the heart changes from a tall tented T wave to drawing out of the P wave and then to drawing out of the QRS complex. Now, the signal that you have very high hyperkalemia, usually more than 8.5 is your sine wave pattern. And this is the grand finale before the cardiac arrest. The ECG now looks like a continuous wave, no flat baseline, just smooth up down curves and like the waveforms, that you can have in a sinusoidal pattern like your physics class. Once this shows up, you're seconds away from a flat line, and this is a code red. Now, why does this happen? It's because the potassium floods the heart cells and the normal flow of electricity is disrupted. So it messes with the polarization and repolarization. And what you find out is that there is more potassium outside the cells than inside the cells. And normally, the heart cell is like a light switch, on, off, on. With too much potassium, the switch can get jammed halfway, and it can just mess up with the depolarization with polarization patterns, causing arrhythmias. Now we're going to discuss examples, right? I've already mentioned that medications could cause hyperkalemia, and those medications could include spironolactone, ACE inhibitors. If they've missed their dialysis, if they're regularly on dialysis and they've missed their dialysis, that should be a big pointer. If they've had a fall or they've had prolonged positioning, housebound, and then on the same position for a very long time, that could be your signal towards rhabdomyolysis, which is a very important cause of hyperkalemia. Also, if they've had severe burns where there's a lot of cell breakdown, you could have hyperkalemia. And kidney failure, essentially, like I've mentioned, your ACE inhibitors is a very important common cause. In many cases, we're able to pick that up when it is mild to moderate by just regularly monitoring patients that are on this medication. But if a patient is symptomatic and they are on ACE inhibitors, you should definitely watch out for that and see if you can stop it in the interim while you're taking other measures. For mild hyperkalemia and ACE inhibitors, usually stopping the medication many times is enough. And then monitoring, especially if the patient is asymptomatic. But obviously, if they're symptomatic, then you would need to intervene. The big three immediate treatments that you could intervene with would be the first thing is if they're symptomatic. I often say people have asked me in the past and said, at what point do you, in any of these three scenarios, do you go in to give treatment? So first off, for me, I'm a believer in context, and this is backed up by textbooks as well. But I'm a believer in the person that says in the in the phenomenon that you should treat your patient if they are becoming symptomatic. Of course, it raises your suspicion, but it's also maybe that signal that you need to intervene. And when I mean intervention, I mean when do you give insulin and glucose to shift potassium into the cells? So then some would even give nebulized salbutamol, depending on how bad the hyperkalemia is and how fast the results they want. But while you're buying time, while all of these treatments are working, perhaps the most important of all is to protect the heart. And especially if you're having potassium levels of 6.5 and above, or you're having a person that's already symptomatic for hyperkalemia, or in any level of hyperkalemia showing ECG changes, you want to stabilize with the heart cell membrane with gluconate. And just remember that what you're using is 10 mils of 10% calcium gluconate over 2 to 5 minutes. You want to repeat in 5 to 10 minutes if the ECG changes persist, and you want to monitor, leave them on a cardiac monitor and monitor closely because that could be the last thing they have before a cardiac arrest. Insulin glucose, remember your 50 mils of 50% IV glucose. I like to remember that because 50 or 50 is quite easy to remember, isn't it? But you could also give 100 mils of 20% glucose. And then you have to monitor the glucose every 30 minutes for hypoglycemia because you're giving 10 units of insulin with it. And basically, you're pushing potassium away from the blood and back into the cells. So And that's the same purpose of your salbutamol inhalers, nebulized doses. It's because you're pushing potassium back into the cells and you're giving 10 to 20 milligram of salbutamol inhaled over 10 to 15 minutes. And it can start to work within half an hour. So again, like I said, it depends on how bad the hyperkalemia is, how symptomatic the patient is, and how fast the results you want is. Sometimes you use sodium bicarbonate, especially if you have very high hyperkalemia. And, in that case, you use 50 mils of 8.4% sodium bicarbonate. The definitive treatment options to remove potassium from the body, you could try. Remember that loop diuretics, furosemide, one of the major side effects that it has is hypokalemia. So if you have a patient that is hyperkalemia and you want to tip the balance a bit, you could give IV Lasix 20 to 40 milligram, and you could do calcium binders like calcium raisins. They are slow onset. I've never had to use it in real life, but they could be helpful in life-threatening cases. Um, and then again, dialysis. If you have hyperkalemia that is extremely high, you really want to call the renal department to see if you can get your dialysis ongoing, especially if it is secondary to renal failure. You know that no matter what you do, you're not going to be able to correct this long term, and especially with resistant hyperkalemia, you really need to think about dialysis quickly. That being said, we're going to look at ECGs with hyperkalemia. Now, what do we see in this ECG? In this ECG, we can see our huge T waves in V2 to V4 as promised, not just in V2, actually everywhere. You can see that there is no defined QRS in your lead 3 anymore. You can find your peaked T wave. There's becoming a sine wave appearance. This is actually what we mean by the sine wave appearance. As you can see, it's so distorted that you can't make a P up, you can't make a QRS up anymore, and it's becoming sinusoidal. And so this is already very high hyperkalemia, and this patient would be having a potassium within the range of 8.5 or above. I've seen a patient with 11 before, so you could have very high potassium, and some have even seen worse, but this would be the pattern in this regard. So, moving on, what we would have is this ECG pattern. What do we see in this ECG pattern? Again, in this ECG, we are seeing our tall tented P wave. And as we can see, our tall tented P wave, most prominent in V2, V3, V4, V5, V6. But we also notice exactly that in our 2, 3, in our other leads, basically, it's becoming bizarre. The QRS is becoming bizarre. It's becoming sine. If you give this a few moments, it's going to be completely sine. In fact, it is already sine as far as I can see. But the bizarre QRS complexes that you can see should alert you to the fact that this is a very severe hyperkalemia. Say you're handed this ECG in the emergency department and say, doctor, look at it. Of course, you should know that something is definitely wrong, and you want to check how is my patient, where oh, they've come in unwell, very lethargic, very weak, non-specific symptoms. Okay, can I see their bloods? Do they have any bloods back? Do they have their what? Do we have VBGs? What do we have? Because they should have VBGs done immediately to at least signal you what you're even doing, while you're taking blood to the actual lab. And if there is hyperkalemia, yeah, trust me, you're going in full on with your hyperkalemia treatment regime. Now, and of course, they're going to be admitted. That goes without saying. They're going to be on cardiac monitoring. You're going to stand by this patient to make sure they're not running into cardiac arrest. You're going to repeat your ECG every time you've instituted treatment with calcium gluconate until you get better ECG changes. And like I said, calcium gluconate is to stabilize the heart membrane. And so you're going to be really looking out for that. Now, what do we also see here? If you notice, there seems, even though we cannot make a proper P out, there is what I would argue, this looks like the P, this looks like the QRS, and we're barely making out a T, but there is definitely a prolonged PR interval going on here. So we move on to the next ECG. And what do we see in this ECG? This ECG is showing a proper sine wave appearance. This is the classical. The others we saw are kind of irregular QRS, bizarre QRS complexes beginning to form a sine wave pattern. And in this ECG, patient would have hyperkalemia of, I think this was the ECG where they had an hyperkalemia of about 10. And so you don't see a tall, I mean, you see a tall T wave, you might argue, but to be fair, you can't really make out a proper wave right here. And so what you're having is a sinusoidal wave pattern. Here again, what do we find? We find a tall tented T wave, right? Just going to annotate that. We have a tall tented T wave in our V2, V3, V4, V5. We have it's tall, symmetrical, it is peaked, and here the patient did have a potassium of greater than 6.5. So this again, and here you can also see that the QRS complexes are becoming benign. Even in the 2, 3 AVF, the tall tented P waves are showing up. And this shows it's quite serious in terms of, and to be fair, once I have hyperkalemia in this kind of an ECG, regardless of what the levels are, I'm going to go in and stabilize the cardiac membranes because the ECG, which is just the tracing of the heart, has shown that the hyperkalemia is getting to the heart cells, and I have no excuse while I'm doing my insulin glucose regimen, while I'm doing my possibly sodium bicarbonate in an acute situation, or while I'm giving them salbutamol via nebs. What I really want to do quickly is to go in and stabilize the membrane and repeat the ECG every 5 to 10 minutes till it becomes better. This is a medical emergency, and you want all hands on deck. And that is the end of today's lecture. I've made it concise and sweet, and and I'll go into the group to get what you think about this, and if you need any other support with understanding hyperkalemia. Thank you.